Welcome to Dental XP. I'm Dr. Maurice Salama, and we're going to be sharing with you the placement of a dental implant following extraction of a maxillary left second bicuspid. We had extracted the tooth atraumatically utilizing a easy extract device from Titan instruments, which allowed us to preserve the entire socket. You can see us closing in on this socket and maintaining it is a very important aspect to immediate implant placement potential. If the tooth is removed without any trauma to the surrounding bone, interproximally as well as labially, we can then go ahead and place our implants. In this case, we went ahead and placed a ankylose, a Dentsply ankylose implant is going to be inserted immediately, with the effort of placing the implant towards the palatal bone, which is more dense, and avoiding the buccal plate by approximately 1 to 2 millimeters. The implant will be placed, as you can see here, to avoid the buccal bone and to have the screw access emanating directly into the central fossa area of the future restoration. We like to utilize the drilling procedure for this implant or any other, utilizing slower RPM revolutions according to the protocol of Dr. Eduardo Anitwa. We will place our drills, the first drills in at 600 RPM and then reduce it down to 50 or 60 RPM so that we can collect more of the bone during harvesting, which is exceptionally good with this system because the drills seem to be very, very useful for the harvesting of bone. You can see us again going in slower RPMs than what we typically utilize and preserving the direction of the implant. You can see the bone being then picked up on these reamer drills, which can be used with hand instrumentation or with ratchet instrumentation and now have a handpiece adapter. We do this with very, very slow machining out of the bone, and you can see exactly how we proceed going over this. This is an excellent device for shaping the implant, the implant site for the future implant, but also for harvesting of bone chips in this area. Now the placement of the implant to coincide with the placement with the preparation of the osteotomy is now being performed. We're simply placing it in and locking it in with hand instrumentation, followed by the ratchet to torque down the implant to 30 or 40 Newton centimeters according to the initial stability readings. This happens to be a very good way to control it when you're placing implants, especially in extraction sites. I prefer to utilize my hands or hand instrumentation, whether it be a direct driver or ratchet type driver, so I can control the pace and the direction of the implant into the socket. And here you can see us slowly bringing the implant down below the gum line and staying away from the labial plate. And this gap area between the implant and the labial bone has been researched, and the jumping distance, the distance between the bone on the socket wall and the labial to the implant, appears to be somewhere in the neighborhood of 2 to 2.25 millimeters, according to some of the work from Botticelli and others. And we seem to be in line with what we've seen from this study, but we still prefer to pack bone into this gap. So I think it's something that is still being researched, but for many of us out there, this gap between the implant and the socket wall remains vitally important to preserve the thickness of the ridge for aesthetics and to maintain the stability of the soft tissue following restoration. We are now removing the implant driver from the implant, and now the cover screw is being removed from the implant so that we can immediately place a healing abutment, or if we would like to, we can select a permanent abutment utilizing this system from Ankylose, which selects the abutments and allows you to try in the mouth utilizing plastic analogs whether or not these abutments would be ideal for the final restoration. And this makes it very easy for us to select the right abutment for the particular area that we're restoring. And this is a standard abutment. The yellow color is identical to a certain dimension. In this case, rather than going ahead and immediately temporizing or selecting abutment, we went ahead and placed a healing abutment into this area to do this as a one-stage surgery, but not with immediate temporization. This happens to be a very safe protocol, one with a very high success rate, and allows us to select our permanent abutment in the laboratory following impression taking. Here's the position of the implant. You can see that gap remains on the buccal between the implant and the soft tissue. You can see how this has been reviewed from placement of the implant all the way through to the placement of the healing abutment, staying away from the buccal plate, and grafting that area is our preferred modality of choice. A single mattress suture to close over that gap, and I think that we've gotten a great result for this patient. Thanks for being with us at Dental XP.